progressive supranuclear palsy and corticobasal degeneration. So we'll start with PSP and then move on to CBD a little bit later, and we'll go over clinical manifestations with some videos from patients, then talk about neuropathology and some biomarkers that help us diagnose these people more accurately during life and the future. And then lastly, we'll wrap up with treatment, at least as it is now with standard of care. So for our tauopathies, CBD and PSP are often grouped together for talks like this. And the reason is a couple-fold. One is that they both manifest with a combination of movement disorders and cognitive issues. I spent a lot of time going into what exactly are those things. They are both neuropathologically characterized by accumulations of tau, specifically 4 repeat tau, at autopsy that occurs in different morphologies. So the tau protein, which is encoded by the MAPT gene, has 6 isoforms, which exist because of alternative splicing of the gene having different microtubule binding exist. So the different entities may have different relative balances of 3R species of tau, where there's 3 repeats and 4R. So things like PSP have 4R, basically 4 repeats of this microtubule binding was there with the presence of the E10 on the one being there, but also a couple of other pathologic entities, GVT and argyrophilic grain disease, but also Guam, FGD, and then things like Alzheimer's disease, for example, have a pretty good mix, pretty equal mix of 3R and 4R, and that's the same type of tauopathy that you would see in primary age-related tauopathy. And then 3R tauopathy is really relegated mostly to fixed disease. So we're going to start with progressive supranuclear palsy. It was originally described as a clinical pathologic entity in 1964 by Steele, Richardson, and Olszewski. And they basically followed 9 patients and had pathology on the majority of them. And they detailed their clinical course, which was significant for them having a number of problems, namely having a very typical type of facial change with a lot of interesting staring, kind of a grimace that they would have. They call it the facial spasticity. These patients would have often vague visual complaints and personality changes, usually very impulsive, sometimes disinhibited. They detailed pretty nicely a vertical, mostly supranuclear gaze palsy, as well as some cervical dystonia, which is tightening of the neck muscles, and mostly was what we call a retrocollis, which is the neck being pulled back in these patients. They often had a lot of slurred speech or dysarthria and a lot of trouble with chewing and swallowing, and a lot of rigidity of sort of the trunk muscles as well. They made particular note to say that this was unlike Parkinson's disease for a number of reasons. The majority of the patients that they saw in this series anyway had no tremor, and they lacked sort of a flex posture at the waist. Most of these patients went on to die a few years after being seen in the clinics by these guys, and the majority of them had died of pulmonary infection. And when they came to autopsy, they noted several abnormalities which helped group together. This was a gross specimen. They saw gliosis of the midbrain and some other brainstem structures. At that point in the 60s, nobody had tau immunohistochemistry, so people were doing silver stains predominantly, and they would see these silver positive inclusions throughout the brainstem and the cortex. And even though this was all done in 1964, all of this stuff really rings pretty true even today. So these days, we think that PSP is probably the most common atypical Parkinsonian syndrome, and probably accounts for around 5 or 6% of patients who will come to our clinic and have Parkinsonism as a presenting symptomatology. We think that the prevalence is about 6 per 100,000, but it's probably a bit higher than that, and I'll explain why we think that. The average age that people tend to come down with symptoms tends to be the mid-60s, and people tend to survive about 5 years after diagnosis. That tends as a mean. There is a pretty wide variance. Some people have a pretty fulminant course and pass away fairly quickly, but there are some subtypes that survive pretty long, actually like 10, 15 years in some cases. So the original pathologic criteria and clinical criteria I need to go over because Eileen Litvand, who is here, was the first author on it and was really one of the first like larger autopsy validated studies for establishing criteria for PSP. And the core criteria involved a gradual progressive disorder with an age of onset above 40. And then they broke it down into 3 levels of certainty. You have possible PSP if you had a vertical supranuclear palsy or slowing of vertical eye movements accompanied by problems with your postural stability, usually falls in the first year of your disease. If you had probable PSP, you would meet that level of certainty if you had both of those features anyway. But you can only reach a definite diagnosis of PSP at autopsy, and that's true today. There's a number of other clinical criteria that people have noted usually to be associated with PSP patients anyway. They often had very, very symmetric slowness of movements and rigidity, again, predominantly the truncal muscles. They continued to affirm some of the old observations from the 1960s anyway, with abnormal neck postures. These people usually wouldn't respond great to levodopa, although there are some caveats to that I'll go into. And again, early problems with speech, early problems with swallowing, a lot of cognitive problems, very cortical in nature, often frontal, although a language subtype has been pretty well elucidated at this point as well too. There's a number of things that they wanted to make sure that they ruled out also. Exclusionary criteria, and I also list that in the right column as well as the conditions that they're trying to rule out anyway. So recent history of encephalitis is something that one sees with that results in a post-encephalitic Parkinsonism, which is actually fairly common after the 1917 Spanish flu, and then we still see it every once in a while today, usually associated with West Nile virus or Eastern equine encephalitis. Alien limb syndromes or cortical sensory deficits are things that you tend to see more with corticobasal degeneration. Same thing with severe asymmetric Parkinsonism. Hallucinations and delusions are very, very uncommon in PSP, and if a patient has them, you should probably question your diagnosis, like do they actually have dementia with Lewy bodies. They talk about episodic memory problems not being very common in PSP anyway. You should consider your diagnosis if that's a prominent feature. And then if you have a lot of cerebellar problems or a lot of dysautonomia, bad problems with blood pressure, bad problems with urinary retention, you might be dealing with MSA, MSA, multiple systems atrophy, which is synucleinopathy. That is another one of our typical Parkinson's. There's kind of an uncommon infection called Whipple's disease that can involve a lot of diarrhea, but also a neurologic syndrome that can look fairly similar to PSP anyway. And then certainly if you have like a lot of disease, like some people look a little bit like PSP as well. Right? This is all great to talk about, but you really got to see some of these people. So what I'm going to try to do here is show you some videos of patients who have PSP and kind of narrate the videos to tell you what it is that we're trying to see and the pertinent findings of that. Better. Okay, so you see this close-up of this guy. This is a neuro-opto guy who took this anyway. So I'm going to detail some of the eye findings that we look for when we're trying to diagnose people. And again, this is one of the core features of PSP. So he's trying to follow the pen with his eyes. It's not really smooth. It's very choppy. That's not really normal. You can see that in a lot of diseases. It's ultimately not very specific, but it says there's something going on in your brainstem. It's not really working well for some reason. This is really a problem. So he is trying to follow the pen and look up. Can't do it. This is what we would call restricted up gaze, an ability to follow the pen or other stimulus going upwards. And you actually really can't do it going downwards either. And that's important. You can pause for a second. You can have restricted up gaze, have trouble looking up in other conditions anyway. You see it a little bit in Alzheimer's disease. Most old people are a little bit restricted anyway, but this is really bad. Like he can barely move his eyes vertically at all. That's unusual with normal aging. That's unusual with really any other neurodegenerative condition. That's a PSP kind of thing. The problems going downwards is actually the most specific for PSP. What they are trying to show you here is that his saccades are also very slow, particularly going up and down. So what they're asking him to do is like to look very quickly back and forth from one stimulus to the other, like the camera to a hand on the side. Right? His eyes are moving super slowly going up. Normally our eyes move really, really quickly when we're trying to do that actually. And they're showing some of the MRI findings that you can see with that also. Get out of here. Other features associated. So those are sort of what the eye findings of PSP will look like. A couple of other things. You're still seeing this lady with the face now?
Yeah, you can see her.
Yep.
This is what we call sort of a PSP stare. Not everybody gets this, but this is not because she's upset. This is actually how their faces will sometimes look anyway. So big furrowed brow anyway, looking sort of distressed. It's actually a facial dystonia. It doesn't have anything to do with how they're feeling, good or bad, actually. This woman has a little bit less of that kind of problem, but she does have what looks like facial masking anyway. And he is showing that her eye movements going back and forth are a little bit slow. And she has also trouble looking upwards. She can only get like 10 or 15 degrees upwards before she's not able to do it anymore. And this is kind of fun. This is what's called, you're looking for something called optokinetic nystagmus. You're basically showing them a ribbon in front of their eyes that has like a series of bars. And it's kind of like counting telephone poles out of the side of a car window. Normally your eyes kind of flick back and forth between the telephone poles. They lose the ability to do that. So you will see that they just can't like track the bars when you're doing that. And then what this guy is showing here is that they have a lot of postural instability. Like she is basically tipping over, usually backwards, almost with no provocation. Barely taking his hands off her, she's falling. So when you say about falls within the first year, they can be in any direction, but they tend to have particular problems falling backwards. Let's skip ahead with this guy. This guy is showing sort of bradykinesia that can be associated with PSP. Right? He's very slow in his hand movements and his foot movements. Pretty much worse on the left side than the right side, it looks like. You know, the examiner is really having to help him get up and down. So there's a lot of Parkinson's associated with this. And this is a good one. He's about to test what's called the applause sign. And he's going to clap 3 times for this guy and say, try to do what I do. Clap 3 times. Clap, clap, clap. And what he's trying to demonstrate is that PSP patients often have a lot of frontal disinhibition and they have a lot of trouble sort of turning that off. They'll just keep clapping. Clap, 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 clap. It's kind of like a blink test where you tap on the head. Now this guy actually has a little bit of tremor. I'll talk a little bit about that in a minute, but I want to show you one of my patients also so you get a good picture of the gait too that can go along with this. So, it might take us a minute. This is a patient of mine. She's since passed away, but she had PSP for probably about 8 years or so before I took this video anyway. So a lot of facial dystonia. She really can't move her eyes vertically at all. It's actually progressed so much that she's having a lot of trouble moving the horizontal plane, which is a late stage finding of the eye movements in PSP. The facial dystonia has made it hard for her to open her jaw. That was kind of a challenging problem for her, maybe eating a little bit harder. Yeah. This is kind of interesting. She had this kind of unique thing where her leg would just kind of lift up. You hear a little bit about what we call alien limb phenomenon, where it just kind of like floats or curls up. And she actually, I think, had just alien leg syndrome, which is a little bit less common. As opposed to the guy that you saw in the previous video, she does not have a ton of bradykinesia. She's very, very stiff in her neck and trunk, but her arms are actually pretty loose. I have her gait. So you see she like pops right up out of the chair. Looks pretty unsteady. You're like, oh my gosh, she's gonna fall. This is her daughter. Her daughter is trying to help her just be stable. She usually walks with a walker. There's a very scissoring gait. This is what we call it. Her legs are sort of crossing over each other because there's extra spasticity in this person. And she's another person who, like, you see she almost like fell over backwards. Unfortunately, that's very common. These people fall a ton. Try to do what you can to minimize that. So that is what PSP Richardson syndrome tends to look like. So the story of PSP over the last several years anyway has been a growing appreciation that there are other phenotypes that can have PSP pathology when they come to autism. The original criteria from Irene and all of the videos that I just showed you are really detailing what we now call the Richardson syndrome of PSP, PSP-RS. And that's really what was detailed in the original 1954 manuscripts anyway. And if you have that syndrome, you have a very, very high likelihood of having PSP pathology when you come to autism. What people started to notice was that people could have pretty varied other clinical presentations, but when they came to autopsy, they would have PSP pathology. You could have a Corticobasal syndrome type of presentation. That. You could have a frontotemporal dementia type of thing, where very disinhibited, a primary progressive aphasia, usually logopenic, or not, sorry, non-fluent variant anyway. You could have primarily Parkinsonism, which I'll talk a little bit too, and then some other more rare phenotypes. But again, when it comes to autopsy, you have PSP pathology. So the PSP Parkinsonism one is kind of important, I think, anyway, because it's one of the more common clinical variants. You see this in probably about a third of most PSP autopsy series, and they can look a lot like Parkinson's disease. With instead of this like axial, more neck, trunk, and eye movement stuff, they'll just have rigidity of one side, a little bit of resting tremor usually, and they can even respond pretty well to levodopa. About a third of them can have like really good responses. Most of the other people will have just mild responses, not really like as robust as you see in Parkinson's, and it usually needs like pretty high doses to achieve this. And as they go on, the efficacy of levodopa seems to wane. But some of them can even develop sort of levodopa-induced dyskinesias, which is what Michael J. Fox has if you ever see him on TV these days doing stuff with his foundation. The motor symptoms of PSP Parkinsonism does seem to progress faster typically than what we see in regular Parkinson's disease. So you have a Parkinson's patient who seems to be like moving along a little bit too quick. You might want to think that this could be what is going on instead. The survival of this is much longer than what we see in the Richardson syndrome guys that you saw in the videos initially. And they probably have a little bit less likely to have haplotype than the PSP Richardson syndrome guys anyway. The cognitive phenotypes that can be associated with PSP pathology, again, a primary progressive aphasia with very, very shortened sentence, loss of grammar, problems with word finding, and some paraphrasic errors. They tend to still comprehend pretty well. And then there's a behavioral variant that looks an awful lot like the regular BBFTD. Impulsive and appropriate, very ritualistic, rigid in their schedules throughout the day, very apathetic, lack of empathy with patients who have those problems. Those have actually been the worst problems as far as the spouse or caregiver is concerned with the apathy and lack of empathy. Pretty crazy. There's some other rare phenotypes where they're just slow and they have some freezing of gait, or they can just have problems with their eye movements without a lot of falling anyway. Cerebellar ataxia presentations are pretty rare, as the PLS, primary sclerosis. What is kind of helpful about PSP anyway, though, is that as time goes on, they tend to accumulate more symptoms and start looking more and more like the classic Richardson syndrome as time goes on. So eventually they sort of coalesce into a similar type of phenotype. So if you keep looking out for some of the cardinal features of eye movement changes and postural instability, like they typically will show up at some time. One of the things that is kind of, if you're going to read, there's a lot that's been published on this, but if you're going to choose like one paper to talk about phenotypic heterogeneity here, this Justine Respondek paper from 2014 is probably one of the better ones, I think. They took 100 autopsy-validated PSP patients and split them up based on their clinical presentation. And what I wanted to really highlight is that some of basically the guys who have PSP Parkinsonism have a much longer mean disease duration than people who have a classic Richardson syndrome with a much lower 5-year mortality. And this is where we get some of the notions where, okay, if you have Richardson syndrome, you know, you have a certain prognosis anyway, but if you're one of the guys who looks more like Parkinson's disease with just the eye movement findings, like you could actually do quite well for several years, more than classic PSP Richardson syndrome. This is a little bit complicated, but I will walk you through it. What they did also for this paper was they had really good clinical characterization of these patients anyway, and tracked when they tended to occur for the patients over time. So supranuclear gaze palsy, those changes in the eyes happen very, very early for these guys who are green. The Richardson syndrome guys, you know, patients with ocular deficit by definition. What was worth looking at, though, is that the blue line, is the PSP Parkinsonism guys, really wouldn't be developing eye movement problems, sometimes until fairly late after their initial presentation, like 10% of them after like 7 or 8 years. The guys with an FTD kind of presentation, barely reaching 50% after 8 or 9 years. So this is very, very difficult to really call somebody PSP if they're not showing these signs. And it can take a long time for them to manifest them. You know, same thing with falls. Again, a classic core feature of the initial criteria. Only a certain percentage, not very high percentage, about 30% of the FTD presentation guys develop those core features even after time. And you can also see how the death rates, a lot of them coalesce eventually, but the PSP guys survive a little bit longer. So this just highlights the challenge of making an accurate clinical diagnosis based on the science alone. So to expand on this, we have a new set of clinical criteria that was put forward by the Movement Disorder Society in 2017. Coughlin first author that. And the general theme of it was to expand the phenotypic diversity that they said could potentially be resulting from PSP pathology anyway, and they broke it up into 4 axes: ocular motor dysfunction, postural instability, bradykinesia and akinesia, and cognitive dysfunction. And then they broke it down by levels. So if you have a level 1, you're like much more likely to have PSP pathology, all the way down to level 3, which is much less specific. So for example, A3, akinesia, like level 3, is Parkinsonism with tremor, and you're levodopa responsive. So that's much more likely to be Parkinson's disease than PSP at that point. You should have other features if you're going to say, like, the person's positive PSP. I'm not going to walk through all of this, but they still adopted the same thing where you have to have an autopsy to really have a gold standard diagnosis of PSP. Probable, which again is highly specific but not terribly sensitive anyway. They try to focus that mostly on the Richardson syndrome with a couple of other combinations of these other clinical features, which is a greater likelihood. I would say that this is mostly something that we would use on sort of a research basis. It's pretty hard to operationalize this in clinic anyway, and there's a lot of overlap between patients if you're going to call them like one of these phenotypes anyway. I think their heart was in the right place. It's just a little bit hard to use this in clinical practice. So what happens when they come to autopsy? So what we see is the sort of pathognomonic feature that we see is what we call tufted astrocytes. These are tau positive. They're kind of angry looking. It's these top two things on the right here. On the left. You see them mostly in gray matter, a little bit in the white matter also. There you will also see these little curled up guys here are called coiled bodies. They're around primarily oligodendrocytes in the white matter. And then also in the gray matter, you'll see these little, we call them globose neurofibrillary tangles. They're around neurons in the gray matter in the white. So this is different than what we see in Alzheimer's disease. There's an awful lot of white matter pathology in PSP anyway. So it's a pretty solid mix of gray and white matter stuff. And where we see it in the brain, we see a lot of subcortical pathology with the subthalamic nucleus and globus pallidus always being affected. Nearly all the time you see substantia nigra and pons involvement too. Less commonly, you'll see some stuff in the hippocampus. The dentate nucleus of the cerebellum is usually hit pretty hard. And the cortical involvement's a little bit varied and matches pretty well with what their clinical phenotype is. There is going to be some staging criteria for this that's going to get published in like the next couple of months anyway. So if you're interested in this kind of thing, there's a big paper that's coming out pretty soon. So what is kind of interesting is that we're not totally sure like whether there are different places in the nervous system where this might originate, or whether there's just sort of a relative difference in the amount of pathology that you see. So we tend to see more cortical pathology in the patients who have focal cortical syndrome. We see a lot of frontal lobe tau pathology associated with the patients who have FTD anyway, versus the people who have PSP Parkinsonism or PSP Richardson syndrome, where you see a lot more subcortical pathology. And those are the general areas that govern those different functions. I'm going to switch over to corticobasal degeneration. Does anybody have questions about PSP though before I try to switch over to CBD anyway? We're going to talk about biomarkers altogether. So
David, it's Diane Jacobs. Can I ask you a question about, you mentioned the shorter disease course to death in people who have the stereotypic Steele-Richardson presentation?
Mm-hmm.
Do we know if that's because of the pathology itself, or maybe the pathology is spreading down to respiratory centers or something like that, or is it secondary to the clinical phenotype? Maybe they're falling more and having more accidental deaths. Do we know what the reason for the shorter disease course is?
Well, I don't think we know exactly why they have a shorter disease course. I think we generally observe greater degrees of pathology, both cortically and subcortically, in those patients when they come to autopsy anyway. The general reason, the cause for death, is usually pretty similar between all these guys at the end anyway, and it's immobility, pneumonias, aspiration. They all kind of end the same way.
Right, the usual kind of thing that gets a frail older person.
Correct. I mean, we don't have like a ton of like traumatic, head injury stuff. Like, don't get me wrong, it happens every once in a while. It's usually not the cause of death though. They usually get a couple subdurals and they're wheelchair bound.
Gotcha. Yeah, no, it's interesting. Thanks.
Yeah. So there's probably something else about them, be it genetic makeup, other type of things, like a seed and soil kind of question anyway, of like, for some reason, those guys have a more fulminant presentation in general.
Mm-hmm. Great, thank you.
Then we're going to move on to corticobasal degeneration, which I think is very tough to talk about. I'll tell you why. So the history is that this was originally described as a sort of a singular entity anyway in 1968. And what the classic presentation was very, very asymmetric rigidity of the stone, often with some myoclonus, which is jerking. Also has a fair amount of alien limb phenomenon with a progressive cognitive decline. Although in the initial criteria, early cognitive problems was actually inclusionary criteria, but that has now been a very, very common issue that can result from this underlying pathology. The early autopsy studies showed focal cortical atrophy, balloon, sick, pale-looking neurons, and then later on widespread tau pathology was appreciated after the what I think is very tricky about corticobasal degeneration is that most people will use this term to really define the pathology. They will use corticobasal syndrome to describe the clinical phenotype. And at least as far as movement disorders clinic goes, this is kind of the place where we are the worst. Like if you see somebody with, you know, in cognitive clinic, just for example, I feel like most of you guys have a cognitive background, right? Like you see somebody with an episodic memory change anyway, and a fairly AD typical course anyway, and you say, okay, I think this person had probable Alzheimer's disease, you're pretty likely to be right. Maybe there'll be some Lewy bodies mixed in there, but it's pretty awful. And we're also really good at doing like regular Parkinson's most of the time. You got somebody with 15 years of Parkinson's disease, they get demented at the end, and okay, almost always right. We're really bad at corticobasal syndrome. You have somebody with a clinical syndrome of corticobasal syndrome, they could have CDD pathology, they could have PSP pathology, they could even have an atypical AD pathology. And a lot of the clinical pathologic studies that have tried to address this, like the breakdown is like, you're 40% right, maybe 50%. That's pretty bad, actually. I guess sort of something analogous would be if you had like a BVFTD patient in cognitive, where you're like kind of 50-50 where there's going to be tau or TDP43 pathology if they come out that too. So these are kind of reflections of the same idea. You can have multiple clinical syndromes that harbor CBD pathology when they come to autopsy, but a corticobasal syndrome clinical presentation is pretty non-specific in a lot of ways. So again, kind of what we were talking about before, pretty low positive predictive value for the actual pathology, 25 to 50-ish%, depending on what study you read. And even the most recent clinical criteria is not totally validated yet, so we're not sure if like the new stuff is any better than the old stuff at the moment. So we talked a little bit. So other things that could present as a clinical basal syndrome phenotype besides PSP, AD, sometimes Pick's disease, I guess, will look a little bit like this. You can see this with TDP43 pathology. And even every once in a while, it turns out, is with non-neurodegenerative diseases. So there's plenty of case reports out there of weird stuff that looks a lot like corticobasal syndrome. So cases of syphilis can occasionally look like this. Cases of really bad cerebrovascular disease. This panel on the right is actually a series of images from a single patient who had a very, very tight, basically gone carotid on the left side anyway, and gave them focal cortical atrophy on that left side. Okay, can you guys see my pointer? So this was an FDG PET study showing hypometabolism of this left side. The structural MRI showed atrophy on this side, especially the parietal lobe compared to the other side. The vascular imaging, they basically had no carotid on that side. And you could see a little bit of diffusion-weighted imaging signal here, indicating that there was not enough blood on that side. This person had a pretty clear presentation with a pretty compelling exam that looked a lot like corticobasal syndrome. They ended up doing like an interesting arterial bypass to try to treat this problem. Some of his corticobasal syndrome stuff got better, but not all of it, unfortunately. So I mean, I'm always getting structural imaging on my patients who have this kind of presentation because you just don't want to miss other unusual things. And I guess the last thing, every once in a while, if you have a really fulminant case of this, you should probably think of Corticobasal disease also. There's a bunch of case reports out there about CJD presenting sort of a fulminant corticobasal syndrome type of presentation. So this also means that our epidemiology estimates are probably not exactly right, but as near as we think anyway. Most people have an age of onset in their mid-50s anyway. The mean survival is about 7 years, but again, a really wide range. Some people get sick and die very quickly, 2 years after diagnosis, and some people do very well, which will survive more than a decade. We think the incidence is a little bit less than 1 per 100,000 anyway, and we think it's the least common of the atypical symptoms anyway. So again, motor features, we'll look at some videos in a second. With very, very asymmetric Parkinsonism, one arm usually very, very tight and very, very rigid. a lot of dystonic posturing, cramping, curling up of a hand or arm, usually limb myoclonus, which is worsened if you stretch out the hand or ask them to do something with it, and then a little bit later they'll get balance problems anyway. And the cognitive features are pretty diverse and interesting. There's a lot of apraxia with this, often ideomotor or limb apraxia. Pretty uncomplicated alien limb phenomenon, which is kind of what you saw actually with that PSP patient, where like an arm will just kind of like lift up out of nowhere anyway. They often have a lot of language problems, and this again, disinhibition. So kind of getting there's a lot of overlap. So let's look at some classic videos. Yeah, so this person has, again, very, very asymmetric. That right arm is like very, very tight to her body. That right hand is curled up.
Can't see the videos again, sorry.
Oh, sorry. One second. Switch over to share. All right. There we go. Let me back up. Okay, that should work.
That's good.
Good. Okay. So the right arm is the one that's primarily affected here. Basically not moving it. It's like glued to her side. The hand is curled up. Dystonic posturing there. The left arm is obviously much, much different. The movements of the left arm aren't exactly normal either. She's still slow and kind of apraxic appearing. The kind of gropes, looks very awkward. Switch on to this lady. This lady, also her right arm happens to be affected. The hand's totally curled up at this point. That can be painful for some patients. It makes self-care difficult, certainly of the palm itself, but they usually require a lot of help anyway. This is just so that's kind of what the classic arm issue will look like. I'm going to show you one of my patients also. I like this guy a lot. So he has a really interesting story. He was in his late 50s. He was actually a computer programmer who worked in a neighboring hospital system and basically was doing epic builds for their electronic medical record system. And the first thing that he noticed that was wrong with them was that he was having a lot of trouble coding. Was making a lot of unforced errors, actually like crashed their system a couple of times, and they took him off of his usual job because his errors were just uncharacteristic and had been pretty detrimental anyway with the system. So his initial problem was basically some type of cognitive issue, but he was seeing me for tremor initially. So I'm checking his eye movements to see if there's any evidence of things that we might associate with PSP. I think this is just worthwhile looking at because this is what a normal exam looks like anyway. He has great smooth pursuit. His saccades are fast, horizontally. He's accurate. Hitting the camera, he's hitting my hand. Perfect. No problem looking up or down. So it depends on how good the transmission of the video is. But the right hand is not normal. It's a little bit slow. Seems to be worse than the left. It's not as bad as the people that we were seeing before. So it's very much milder. And if you're noticing, every once in a while he jerks. His whole body jerks. And he's basically having intermittent generalized myoclonic. I'm checking for bradykinesia in his feet. He has a little bit on that right side. And the left side gets interrupted also. So he's mild bradykinesia with the feet too. I'm looking for a resting tremor here that you might associate with regular Parkinson's disease. I'll tell you that he does not have that. He has a jerky, slight postural tremor that affects the right hand more than the left hand. And I'm asking him to raise up his hands like he's saying stop, because that brings out myoclonics a little better in some people. You see that the right hand's like wobbling a little bit, just like little tiny jerks. So he has what I would call a very, very mild myoclonic tremor. And again, there is an intention component to it where if he gets close to his nose, he has some issues anyway. So his walking is not too bad, but he is not swinging his right arm. So the same one that looks slower and has the tremor also isn't moving that much. Now he does not have dystonic posturing. I will say that, you know, I had followed him for a couple of years, and he developed more problems, unfortunately, as we went. I think that if you saw him like initially, and maybe you're going a little bit too fast, you might be tempted to call him regular Parkinson's disease. But the things that are atypical for that is the early cognitive complaints anyway. The jerky tremor that he's got. And yeah, so I've been following him for a couple of years, and unfortunately, he's developed a more classic corticobasal syndrome presentation. Our right arm has become a lot less useful. He's actually developed frankopraxia. He's developed a pretty bad non-fluent aphasia too. Pretty sad. So also similar to the PSP case, not everybody presents classically. So only some people will have like some of the more classic presentation features with limb rigidity or one side that gets pretty stiff anyway. Most of those things will become apparent a little bit later on in the course of the disease anyway, but they're not universal at presentation. Even some of the things that we consider like sort of core features like myoclonics or limb dystonia anyway. And that's as far as like motor symptoms go. I mean, cognitive stuff, like most people will complain of some degree of cognitive impairment anyway. And limb apraxia, only about half of people will have that initially, and only a few more of them will have that a little bit later on. Right? So even the core features of what we think are like really defined corticobasal degeneration anyway, might not necessarily emerge even later on in the course of the disease. And you're probably hearing a lot of overlap. CBS and PSP have a lot of similar features. There can be a lot of overlap with them anyway. So a lot of these guys with corticobasal degeneration will get some eye movement abnormalities too. And I wanted to show you at least one person, just because I want to make sure we have time for stuff at the end, who has sort of an overlap syndrome. So it's pretty common to see like a couple of features of both, which makes it even harder to actually do. Switch the show. Yeah. Okay. So he has a bit of a stare. His speech is very affected. It's what we would call a spastic dysarthria. It's very, very gravelly. It's very, very slow. He also has a lot of trouble moving his eyes vertically and a little bit horizontally. And was not 100% sure about this, but I think what he's probably doing is something called oculomotor apraxia, which is where you can't really figure out how to move your eyes. You actually start an eye movement by moving your head, and then your eyes catch up a little bit later. So he has some like PSP looking eye movements anyway, and very PSP voice. But you'll notice already that his left hand has a lot of dystonia and a lot of apraxia. It's not quite curled up like the guys in the YouTube video, but he's like looking at his hand like it's not even his. I'm asking him to do a thumbs up now. Just trying to figure out how to do it with the bad hand. Really difficult time giving me a thumbs up on the side. So I'm trying to make him the pointer finger, just this, finger guns. Very slow, very challenging. A little better with it, definitely better with the right hand on the left side. Just trying to show me how you would write with the pen. So that's a sort of idiomotor apraxia. He's not really sure what he would do with the pen. This is what we call a limb as tool error. Classically, if you ask people like, show me how you comb your hair, show me how you would hammer a nail, instead of mimicking like they have the tool in their hand, they'll just use their hand as if it is the thing. Rake their hand through their hair, they'll like use their hand like a fist to hammer something instead of pretending like they have their hand up. So he's kind of an example of what I would call sort of like a bit of an overlap syndrome, where he has eye findings that look a good bit like PSP in a way, but he has a lot of corticobasal syndrome-esque apraxia, as well as some of this more parietal lobe with referable cognitive problems. So again, the general story has been we continue to recognize that other clinical phenotypes may be associated with underlying corticobasal degeneration pathology. We are still focused on getting an accurate diagnosis of corticobasal syndrome anyway, but now we're recognizing that some patients with frontal lobe dysfunction, some people with primary progressive aphasias, and even some people with things that look a lot like PSP anyway, some of them will harbor corticobasal degeneration pathology too anyway. So we still break it down into probable and possible, depending on how many of these features that you have anyway. And you have to have a gradual progressive disease that is greater than 1 year. Again, if it's less than 1 year, maybe think a little bit about CJD, Creutzfeldt-Jakob. We still focus on people who are over 50. It's also very unusual to have a family history. So there's like very, very few case reports of any type of true genetic mutations that cause this kind of thing to run. And that actually worked its way into the exclusionary criteria for likely corticobasal degeneration. So other clinical features that are associated with other diseases, classic color-rolling tremors, Parkinson's, hallucinations, again, very uncommon in these guys. It's usually associated with synucleinopathy. You don't see a lot of cerebellar signs out of them. If you see a lot of cerebellar signs in ataxia, it's probably MSA. Upper motor neuron, lower motor neuron stuff, you see in ALS. Believe it or not, this kind of tau pathology can get into the primary motor cortex, which is why they were talking a little bit about this in the criteria anyway. Different types of primary progressive aphasias, like a semantic variant or a logopenic variant, that's more likely to be TDP-43 than CBD pathology. And of course, they don't tend to respond great to levodopa. Some of the PSP guys do, but the CBDS and the CBD guys don't do it quite as well. The neuropathology that you see when they come to autopsy, you'll see focal cortical atrophy, a thin corpus callosum, and usually a depigmented substantia nigra. The feature that you want to take away from all of this is what's called astrocytic plaques. This guy down here. This is the more specific of the features. They can have some coiled bodies, sort of tau-positive free tangles, and some pretty ugly-looking balloon neurons. These other things are a bit less specific. The astrocytic plaque, which is why I show later, is really the most specific neuropathologic. And similarly, you will see a variety of relative densities of pathology that matches up pretty well with what their clinical symptomatology was, with more cortical involvement being seen in those who have multicortical syndrome, like FTD, like non-fluent aphasia, versus more brainstem involvement with the guys who have a more Parkinsonian type of phenotype, those with a lot of dystonia. So just to review, PSP has tufted astrocytes. Corticobasal degeneration has astrocytic plaques. You can see coiled bodies in both. This is as opposed to some of the other tauopathies that you know. So Pick's disease, for example, which is VR tauopathy that we're not going to talk too much about, has these little round balls. You see it a lot in hippocampus, and so diagnosis is pretty easy under the microscope. Primary age-related tauopathy is a 3R4 mixed with these like flame-shaped inclusions, like Alzheimer's disease tau. ALS has these like ALS due to tau have these little blob-shaped ones. Because these things are so difficult to work with on the clinical side, we are always looking for different biomarkers that help us be a little bit more accurate. As far as PSP goes, we look for midbrain atrophy, which is where we see a lot of the neuropathology. So that's, there's a couple of radiologic signs. The hummingbird sign, you're supposed to see that this area here looks a little bit like a hummingbird. It's mostly because this part of the brain is very shrunken. If you look at it in an axial view and look at the midbrain, which is the structure here, some people call this the morning glory sign, other people call it the mouse sign. Mouse here. These signs tend to be more apparent on MRIs later in the disease, unfortunately, after a significant amount of atrophy occurs. It's a little bit less helpful earlier on in the disease course, unfortunately. There is some quantitative MRI measures that are out there that are not really part of routine clinical care, where you can do different measurements of ratios of brainstem structures that actually gets you some pretty good sensitivity and specificity. Right? So if you're doing this for a research basis, you can actually get pretty good using it. Corticobasal syndrome, we have a lot less on that side just because a lot of this is not clinically validated, unfortunately, but you will see on the clinical side of things both with cortical and we don't have a good PET tracer really yet. Tau tracers, a whole bunch of them going through development. The one that's the furthest along is for tau sapir, which seems to work very well for Alzheimer's disease style tau. Doesn't seem to bind as avidly to 4R tauopathy style tau anyway. These are some examples of, if this is a healthy control down here, how bad an Alzheimer's brain looks like with this tracer. You see a little bit of elevation in PSP and corticobasal syndrome guys, but it's really not that impressive. So I'm not totally sure if that particular tracer, how good it's going to be for the failure tau. People are still working on that. There's a bunch of other tracers going through the pipeline. We don't have great. All right, so CSF in patients who have these things, you don't see huge elevations in tau typically. You might be able to get an AD-like signature and say like, oh, I have a corticobasal syndrome due to underlying AD pathology. Like you could try to get that far with a lumbar puncture for amyloid and tau. Neurofilament light chain is a non-specific, it could be measured from blood or CSF, but it's a marker of neuronal damage. It's elevated in all atypical Parkinsonisms versus regular Parkinson's disease and healthy controls. And it wouldn't help you tell them apart, but it might help you tell somebody from regular Parkinson's disease at least. And the last thing, which is still very much under development, is real-time quick induced conversion, where you can take a sample of a patient. If they have some pathologic amount of tau, it may induce further templating to sort of grow and grow within a bath of monomeric tau anyway, to the point where you can actually detect it. And this has been already well pioneered in alpha-synuclein and is a little bit less defined or a little bit less developed in 3R and 4R tau. But people are working on this as well as whether they can make it work for PSP patients. So we might have some molecular specificity as far as biofluid biomarkers in the next a little while, a couple of years maybe. So it's underdeveloped. So treatment, unfortunately, is one slide. Treatment is symptomatic and based on what symptoms they have anyway, and we're doing it for both conditions anyway, because you're assessing the motor and cognitive features that people have and trying to treat them as best you can. I'll always do a levodopa trial for these guys anyway, even if they don't respond as robustly as Parkinson's patients do. I'd say the majority of patients feel that levodopa helps them, even though I can't always see it myself. Whatever is going on, they say they feel a lot better and they don't want to come off of it, basically. And a proper levodopa trial should really be more than 1 gram per day. So you're talking like at least 3 to 4 pills, 3 to 4 times a day, which is pretty high compared to what you would normally do with a regular Parkinson's patient. I would say anecdotally, they can withstand this. PSP patients especially, you can use very, very high doses. They don't seem to get nauseous and they don't seem to get basically anything. So I would keep pushing it to try to get some benefit for their rigidity anyway. And amantadine might be helpful in one study. You can do Botox for a really stiff neck or that curled up hand that you saw in the Corticobasal guys. Sometimes they'll have a lot of eye movement, eye changes like blepharospasm. You can use muscle relaxants for spasticity sometimes. You got to be careful because that can make them sleepy and sometimes fall more. If they drool a lot, you can do Botox for salivary gland stuff here and here. You got to be careful about the under the chin ones because a lot of these guys already have some problem swallowing. A lot of these guys have urinary issues, a lot of urinary incontinence frequency, and there's a lot of mood changes that can happen too. Both dealing with a chronic illness anyway, but some of it's probably disease specific, especially pseudobulbar affect, who have these uncontrollable bouts of laughing and crying that are either minimally provoked or just don't have to do with anything anyway. It's very distressing, but dextromethorphan quinidine actually works really well for that. It's a little bit expensive, so their insurance isn't paying for it. You can use some of the SNRIs, they work okay, but dextromethorphan quinidine works better. Physical therapy helps them not fall. Weighted walkers are probably better than anything else. You want to make sure they're not falling backwards, not the cheap little gray 4.1s they give in a hospital. You need something heavy so they can hang on to it. Speech and swallow therapy for communication strategies, message boards if they're having a lot of trouble with the dysarthria anyway, and making it safe to eat. You can have occupational therapy folks help out with some of the home safety and adaptive strategies anyway, and social and palliative care is always essential, especially when we progress and talk about transitions of care either to assisted living or to hospice anyway. So multidisciplinary and coordinated care, we need it all the time, more of it. So that is all I got. I'm a little bit over time, but I am happy to take questions. Thank you for letting me talk to you guys. I hope it was useful and that my toddler wasn't too distracting.
Dr. Coughlin.
Hey.
Hi. I was curious about the RT Quick.
Yeah.
Can you do that on CSF fluid or would that be post-mortem, like for the tau pathologies?
Right. So you can do this for, it depends on what assay you're talking about. It worked pretty well off of brain homogenate, off of post-mortem, but people are doing it off of CSF and even other tissues at this point. Like there's a couple of papers about submandibular gland stuff for alpha-synuclein, nasal brushings and biopsies. That's a pretty rapidly evolving field anyway and looks very promising. But yeah, people are kind of pushing it forward, trying to test whatever you can.
Yeah, thank you.
David?
Hello, how are you? I like the background.
Oh, I'm sorry, I'm not sure what I'm showing right now. Which one is it?
UC San Diego Health.
I have a couple of questions. I don't want to take all of your time though. So if anybody wants to interrupt me, please feel free. My first is the hummingbird sign. You quoted 100% specificity. Do you believe that?
Not entirely.
No?
That was from a pretty well done paper from 2012 anyway. I mean, and what they had done was these were autopsy validated studies, and they had antemortem MRIs, and they gave it to the radiologist and said, is there hummingbird sign or is there not? Do you think this person has PSP based on their MRI? Do you think they don't? And they did this for a handful of other atypical Parkinsonism things too. And again, that was the basic finding, is that most of these things were pretty specific. If they were there, that a good, well-trained radiologist could pick it out. But they were not terribly sensitive. They were just right. You know, I think it's hard because, like, ultimately it's a structural imaging biomarker, so it kind of by definition lacks a fair amount of specificity anyway. So I think if you had, you know, the right CBD patients who had a lot of Parkinsonism and, you know, some of these eye movement changes, you probably could see a hummingbird sign. I think it's much more likely in PSP anyway, so it raises the probability of that being right, but it's probably not 100% like specific ultimately. I think we really need like molecularly specific biomarkers, be that PET tracers, or maybe the RT-Quick thing will develop in such a way that we'll be able to tell, you know, PSP from CBD pathology, but we're not quite there yet.
Do you do vessel imaging on anybody with focal atrophy?
Oh yeah, I think it never hurts anyway.
Yeah.
Definitely, basically anybody who has an atypical Parkinsonian syndrome, I would love to get an MRI. Usually I'll add the vessel imaging on if it's a Corticobasal syndrome patient specifically anyway, or they have like a focal cortical syndrome, just to be sure. And again, this is not terribly common, but again, if you catch something that's intervenable, like, it's not so hard to add the MRA onto the MRIs. It's already.
It's not a knee-jerk reaction for me, so I'm wondering how many, you know, stenoses or critical stenoses I've missed.
Probably not a lot. I mean, you know, there's certainly other things that would be more suggestive of vascular, you know, etiology to these things, but I do it anyway. Can't say I've ever caught anyone. I heard a story about the last place that I worked where they did catch one, but that person also had like some limb shaking, TIA kind of stuff going on. There's other things that made them think it was vascular besides just the movement and cognitive stuff.
With the presence of any restricted diffusion on the standard MRI, would that be enough to, could you wait to do the vessel imaging until you see evidence of diffusion restriction?
You could. It just means that it's kind of hot. It's ongoing anyway. My general thought has been like, they're getting a scan already. They're not getting any extra contrast necessarily for a time of flight MRA anyway. Like if they're going to be in there anyway, you might as well just get a couple extra sequences and put it to bed in one trip.
For pseudobulbar affect, you suggested SNRIs rather than SSRIs.
Oh, I might have. I feel like I've seen some data on venlafaxine that was okay for that anyway. But you're definitely right. Like, I think SSRIs like have some like decent evidence of being useful also. But I really have found like dextromethorphan and quinidine.
Yeah. Yeah.
They're just like, oh, it went away. And you're like, oh, that's great.
Yeah. But so you wouldn't recommend one over the other if they're on an SSRI already, increasing the dose rather than switching?
I guess if they're already on one and the pseudobulbar stuff is still happening, I would still make a play for the dextromethorphan quinidine, and if insurance denied it or it ended up being really expensive, it'd probably work with what they're already on, but it'd probably still shoot for the new Dexter if we could anyway.
I have one last question. Keppra for myoclonus.
Yeah. So interesting. The guy whose video I showed you with like the very early Corticobasal syndrome, I'll tell you his story. Like, I tried levodopa for his Parkinsonism. He hated it. It actually, it like made him feel just bad. He couldn't really say what it was. So as he progressed, it became very clear that like the myoclonus was actually more problematic than anything. So I tried him on Keppra, and he did okay with that, but it like wasn't good enough. He still had a lot of myoclonus, and then when I tried to work it up, he got kind of dizzy. And I've seen plenty of patients get kind of dizzy on Keppra also, so I think that is related to the drug anyway. So yeah, I definitely will try Keppra anyway. What I ultimately did with this guy, which raised a couple of eyebrows, is I gave him some Depakote. And low-dose Depakote was actually very helpful for his myoclonus. It was like 250 milligrams, like twice a day or something. So yeah, if I'm working through myoclonus type symptomatic treatments, Keppra, Depakote, clonazepam are probably the best ones.
Okay.
But certainly have side effects that you gotta wade through.
Thank you. We've had discussions about this offline already, but the overlap with particularly CBD or CBS and how frequently we find we're so bad at predicting what the pathology is. You highlighted that really well. Thank you.
Yeah, and what I generally hope ends up happening is that we will sort of adopt this sort of parallel nomenclature where you say, I've got this phenotype, and then we're doing some testing or molecular characterization to say it's due to this underlying pathology. Actually, the video of the guy with the early corticobasal syndrome that I showed you, he got involved with one of the biomarker studies through our cognitive group at Penn anyway, an amyloid scan that was extremely positive. So my best characterization of that guy is he has corticobasal syndrome due to underlying atypical AD pathology. And I think that if we can get like to that level during life with some degree of specificity, like then we're really going to be cooking anyway.
Yeah.
So I had a question kind of following up on a very similar topic. So why do you think they present so differently? Is it a different underlying distribution of pathology, or is there concomitant pathology of something else? Or so do the people with the Parkinsonian presentation of PSP, do they also have some alpha-synuclein pathology around, or are they just purely just PSP and they also happen to present extremely Parkinsonian?
No, this is a good question because we're not well. I think most of this goes down to just localization. The guys who have a lot of Parkinsonism, they just have a lot of these PSP changes in the nigra and the striatum, the globus pallidus usually also anyway. So what we're able to do in clinic is really clinically characterize them anyway. Like, okay, you have Parkinsonism, so I know probably what parts of your brain are not working very well anyway. And then depending on some of the other features, you have a certain probability of being right with whatever pathology you think is going on. We can't be totally sure until we actually have like accurate in vivo molecularly specific biomarkers anyway to say like, oh, this person actually has tau and I can see it and it's starting there. And then it's moving to there 1 year later, and then it's moving to there 1 year later. Unfortunately, I love neuropathology. I think it's really great and everything. It's just that we're seeing people at the end when they've already accumulated all these things. We kind of assume that as pathology goes, it's sort of a linear fashion, that the places that are affected earlier get the most pathology anyway. But that's not actually really guaranteed. Like, you're going to need better like imaging stuff to like really show the longitudinal change to say how this really progresses with certainty.
Yeah, so for PSP specifically, are there any good workups like that, at least with pathology, that would show how it tracks longitudinally? Or, I mean, are there different pathologic subtypes of PSP that are characterized? I just don't know the landscape very well.
Some people have argued that there are some with like greater cortical involvement versus greater subcortical involvement. That matches up with their presentations anyway. The paper that's going to come out in a month or two anyway is going to make kind of an argument based on this sort of conditional probability of where the pathology is to say that it probably begins in the subthalamic nucleus and maybe the regions of the globus pallidus and then probably spreads from there anyway. But it's not as well worked out as like we think that it is for Parkinson's or Alzheimer's anyway.
Okay.
There's just not enough of these brains to go around anyway.
Sure.
Hey. We'll outside in a second.
All right, no, that's great. Thank you. That was a great presentation. I appreciate it.
Good. The fellow was moving fast, but I'm glad you guys got to see the videos anyway.
It was wonderful. Thank you so very much. And you are such an impressive multitasker. I met you at the beach. That was really well
It's the
done.
new normal.
Well, with that said, I really appreciate it, and won't hold you up any longer, but we really appreciate you taking the time and doing this. This was really good. And
I'm glad you guys liked it.
yeah.
Thank
Yeah.
you.
Thank you. It was really great.